We're going to start our next session. This is actually one of the sessions I was looking the most forward to. This is going to be a panel discussion between the center and the 4 provinces. We're going to talk about the local challenges and kind of how to work our way forward. So our moderator is going to be Dr. Saeed Hamid. I'm going to invite Dr. Saeed Hamid. He's my teacher and my mentor. He is the professor of medicine at the Aga Khan University, Karachi. He's a member of the technical advisory group set up by the Federal Ministry of Health. He also chairs the WHO Hep C guideline development group and is the member of the advisory council of the Hepatitis Fund Geneva. Dr. Saeed Hamid. Now I'm going to invite all our distinguished hepatitis control program heads to come and take the stage. Before I invite them, I'd like to invite Dr. Atiya Abro. She is the Deputy Director Programs, Ministry of Health, and is going to represent the center. I'm going to invite Dr. Zulfikar Darejo, who's coming from Sindh and is the Hepatitis Control Program Sindh. I would like to invite Shoaib Kurd. He is the Hepatitis Control Program Director for Balochistan, and Dr. Asghar Khan, who is currently the Director, Hepatitis Control Program, KPK. The Punjab's Hepatitis Control Program Director was unable to make it, so in his replacement, I'm going to request Dr. Usman Ali Khan, who's the Deputy Director of the Hepatitis Control Program, and also be giving a talk later on to come and join the stage. The mic is, Dr. Saeed, given to you for a question for a panel discussion. Thank you
very much, Amara, and thank you for this opportunity to discuss how are we going to implement, or what are the issues and challenges and the good things that we can do with this program that has been announced both at the national and the federal level. So let's just start from the federal level, and we have Atiya Abro, who's the Deputy Director for programs in the ministry, and she's also now involved with us in our tag. So she's really a welcome addition to the tag. She keeps us straight and narrow. So let me give the mic to her first of all to outline the federal perspective and how she sees this program moving forward. Dr.
Thank you, sir. Thank you so much. Before I start discussion, I just want to make a little correction. My name is Atiya Abro, not Abro. So it's Izzato Abro al Abro. But I'm used to people naming me like this. Anyways. So thank you very much, sir. We have been listening about the Prime Minister's elimination campaign since yesterday, and even before that, in the ministry, we have been working with the Prime Minister office on the PC1, which we presented many times before now. But back in May this year, we were asked to put up again the PC1 to the Planning Commission for approval. And at that time, after various meetings that were held in the Planning Commission with the ministry, the Planning Commission asked ministry to get provincial commitment for the said program. And afterwards, we had many consultations with the provincial program managers and with the DG Health Services of all the provinces and federating areas. And at the same time, we had the meetings in presence of the member social sector from Planning Commission also. And after a lot of discussion, we were asked to get commitment from the provinces that they will be adding the share allocated to them in the form of their PC1 or in their ADPs. And then this PC1 will be approved. After the discussions through our Secretary Health, we approached the Chief Secretaries of all the provinces for giving us the written commitments as we were asked by Planning Commission. But so far, we have not received any written commitment from any of the provinces. But during these discussions, all the provincial program managers and all the Director General Health Services who have been a part of these consultations, they have all committed that as the keeping in view hepatitis as elimination of hepatitis as a national cause, they are all committed to eliminate this from Pakistan. And as they're all already working, we all know that after devolution, the vertical programs were devolved like other programs. Hepatitis program was also devolved to provinces, and they are now fully autonomous in implementing their own budget according to their own targets. So they are all committed. They are all sitting with me, and what we at the federal level and they all at their respective provinces, we just need to convey it through this forum that all the provinces are committed to carry on their commitments as previously, and as now they are again asked to take it forward with more zeal and zest, and with the support. Obviously, previously ministry was previously also supporting the programs in the form of technical assistance and guidance. But now, as we have been told that we will be, federal government will be giving in-kind support to also to the provinces. They are all committed, and what we need to just get a go-ahead from Planning Commission so that we can develop an implementation plan in consultation with all the provincial program managers and in consultation with all the technical advisory group members, so that we can start the campaign as early as possible. At this time, we are all committed, not only at the federal level, but I can assure that all the provincial program managers, they are also committed, and all the provinces are doing very well in their own capacity. What they need is an add-on support from the federal government. And right now, federal government is obviously ready to support the provinces, and we just need a go-ahead from the high-ups. And then we will start developing the plan and the strategies, how we are going to take it forward across the country. And I will stop here. And
Thank you, Dr. Atia. So from what I can gather, two things. One, that the commitment is there. I think that is very clear. Every province and the federation are committed to this. We've got at least 4 provinces represented here. There may be a difference in perception of what exactly the provinces would be required or asked to do. That may be one thing. And secondly, I think we have to recognize that every province is at a different stage in terms of elimination and a different stage in terms of the game, as it were, right? Some are far behind, some are a little bit behind, some are way ahead, and so on. So it'll be nice to hear from the provinces now to understand what their perspective is based on the real life situations that they have in their provinces, and perhaps also link this to what the PC1 that has been approved will, how do they think this will help them, or if they think how should it help them, right, in terms of the problems and issues and challenges that they may have in their own provinces. So we can start from here. We can start from Dr. Zulfikar Tarejo from Sindh. Ji.
Thank you, sir. Actually, we have already written all this in the letters which have been issued to the chief secretaries through Secretary Health. Even the monetary share according to the prevalence in each province that has already been shared. What we will be offering will be in-kind support, and that will be result-based. There will be a consensus on the key performance indicators, and according to those indicators, they will be getting reimbursements. When they show results, they will be getting more commodities. Along with this, obviously, we will be developing a communication strategy. And obviously that will be at the national level, all the provinces, with the consensus of all the provinces, because we all know that there are diversities, there are cultural diversities, there are so much variations among the provinces that it is obviously federal government never imposes anything from its own. We always take all the provinces on board, and we develop anything with the consensus of all the provinces. So that communication strategy will also be developed in consultation with all the provinces and the federating areas. And then this program also includes development of information system as well, because for tracking progress, we need the information system, and we are already working on it. In Punjab, it's already working, and in some districts of Sindh also. We are thankful to our partners. They have supported us in the development of management information system. And what we are thinking is that we can develop it at the national level and get it integrated with the main hub, which is at the National Institutes of Health, so that the data can be monitored on a regular basis. And all these points have already been discussed with the provinces, and by even not only by the ministry, but also by the Planning Commission. And they're all very well aware of what federal government requires from them and what they are going to get. Though the modalities have yet not been finalized, how it will move, that is still to be discussed.
So let's start from Zulfikar. So though two points, Zulfikar. One, what are the 2 or 3 major challenges that you have in your province that you're facing? And number 2, how do you expect the PC1 as it is now to help with those challenges so that you move forward?
Thank you, sir. Sindh government is committed to give 50% share to federal, but it is to be decided.
So Mike.
It is to be decided modalities and mode of transaction, how Sindh province 50% share will be given. So at present, so we have budget allocation about 3.2 billion for Sindh province, which covers screening of B and C, PCR and treatment, both, and vaccination of B. But that budget is headwise. We spend that on headwise, like for B medicine, for C medicine. So at present, we are doing average 3 lakhs screening per month. But nowadays we have problem reactive cases as per WHO survey, 6.2% prevalence. More than I have more than 1 lakh reactive cases, which are in process for PCR, and so which needs huge budget for PCR than treatment. So we have limited budget. If we want for these cases, PCR and treatment, we need 6 billion. So other problem we have awareness. We have no any head for awareness in domestic budget, and digitalization. We have no software. We are paper-based information. recording. And we need unified recording reporting tools for at national level, because each province gathers information on separate tools. So other HR issue is also there. These are the main issue.
So from what I hear from you, the two things that the federal program can certainly help you with right from the start is diagnostics and medications.
Yes,
Right?
as well as
Because you are screening very well, you're screening a large number of people, but you're not able to link them to care for now, right? So a combined effort between the provinces and the federation for diagnostics, for PCR particularly, and for drugs, medications would be probably your biggest priority.
yeah,
right?
In kind we want support.
Right. Okay. Can I move to Dr. Shoaib, please?
Thank you,
From
sir.
Balochistan.
I don't know from where to start, a long list of issues. But I'll come with the budget. As our program is on the regular side, and we have annual budget of 160 million per annum. With this, this is for the whole program, for the hepatitis B, for prevention, for hepatitis D and C. And as for the screening, with this amount, we can just do the 1% of screening of the Balochistan, 1%. And with that positivity rate or the prevalence is like 3% in Balochistan, like 3,000 patients, and we can cater from that screening. And we can do the treatment with this amount. But if we go for the vast screening or the mass screening or the screening when advanced to 10% of the whole population, for that, that would give us about like 30 to 36,000 of cases of hepatitis C per annum. For that, we don't have the resources. So what I see from the federal PC1, that the commodities, internal commodities, like the hepatitis RDT kits, we can increase the screening and we can give the treatment, we give the PCR. But the question is that with just the commodities, where are the operational costs to utilize these commodities? This is the point, what I'm asking for. This is the major issue. And we also have issues with the surveillance system, like Dr. Atia Abru said, they are developing a surveillance system that would be okay and welcome. And like a monitoring unit, I think they're also providing a monitoring unit for the province. And one main issue, the instance of the government of Balochistan from the secretaries of that the allocation of the budget is on the prevalence, I think. The instance and is also written in the summary. And for the letter of the pledge, we have written a summary to CM. Because it was like 50% pledging of the amount, and like for 5 years, my regular budget is just 160 million. And for 5 years, it's like 800 million. We lack like 1,300 millions like that. So for pledging with the federal government, it should be approved by the CM. That's what the secretary thought, and he sent a summary to there. If it's approved, it will be beneficial. If he approves it, that could be reflected in our PSDP, that 13 lacking, and we can use it with our own parallel PC1 with a federal PC1. That would be beneficial. So we're waiting for that summary to be approved. As it's approved, we will pledge with that. What was the last point? Okay, sir. No, thank you, sir.
Thank you, Dr. Shoaib. So what you have pointed out are slightly different things to what, or a little bit different things. Ji.
One point. The stance of government of Balochistan is that this amount is being given on the prevalence rate. It should be on the NFC award. That is 9%, I think, of the Balochistan. If it is a federal budget or something, the instance of the secretary and the government of the Balochistan. What is also written in the summary sent to the CM. Thank you.
So I think this is an important point. at least from me, it would be important to not link it perhaps to the prevalence, but to link this to what is expected from that province in terms of activity, in terms of screening, diagnosis, treatment, and so on, right? That is the point that you're trying to make. Yeah, okay. Thank you.
Sir, it's going on. Sir, there is no PC1. Still अभी कोई PC1 तो है नहीं. जी हाँ. 2.1 billion, sir. जी हाँ. For as of NSC, it would be like 3 point something billion.
Sir.
As far as Khyber Pakhtunkhwa is concerned, we have integrated project, integrated HIV, hepatitis, and thalassemia control program. We have for 1 year, the allocation is 516 million, out of which for hepatitis component, it is 313 million. If now we come to the federal the component, so we have 5.9 billion, which on average it comes like 1.3 billion per year. For that calculation, we need to allocate 1300 million per year, while on ground we have 313 million. So this is a big challenge. Yes, of course, they verbally in our discussion, it happened that we can calculate the HR involved, the infrastructure involved, and we have put these inputs in our note for this the commitment letter, that we can add on these expenditure or allocations in the same. However, having said that, what I see that the support from the federal PC1, we will be able to shift our allocations for the medicines or diagnostics for hepatitis C to the hepatitis B component. For example, when we will be going to the communities, to the far-flung Tehsil headquarters hospital and RHCs, and even in the community, if we are going to start screening, so we will not be doing only screening for hepatitis C. At the same time, we will be doing screening for hepatitis B as well. So I think the resources which we have, the provincial the fund will be allocated more towards hepatitis B, while we will be getting advantage of hepatitis C from the federal side. Moreover, unfortunately, in our PC1, provincial PC1, we have only budget allocated for the medicines and diagnostics. Awareness, prevention side is almost zero. So we can jointly sit together. Yesterday we were discussing last night. So inshallah, we will plan 1 or 2 days the consultative meeting at Islamabad, where we can devise the strategies for the implementation of the federal PC1, how we for the activities to be planned. As far as challenges are concerned, unfortunately, last year, I had almost zero budget release for the project. I received only 25 million. 25 million, you can see that for 3 diseases, I received only 25 million because of the financial constraints. So I'm not sure how much in this current financial year I will receive, because we had some issues with our PC1. So luckily, we have approved our PC1, addressing the loopholes which were there in the PC1. And one thing that we will be needing more HR support if we want to eliminate hepatitis C and to control hepatitis B, because yes, of course, MIS will be developed. And I heard that some communication support will also be there. Yes, of course, for this communication and surveillance M&E side, we need a strong proactive team so that we go to the field and we create an environment where the people they get aware and sensitized, and they get ready to be tested and treated. And a strong surveillance system. So This is all from my
Thank
side.
you,
sir.
Dr. Askar. All your points are noted. Let's go to Dr. Osman and then we will come back to further discussion.
Bismillahirrahmanirrahim, from the Government of the Punjab and Primary Secondary Health Department Secretary. I am really grateful to Professor Dr. Saeed Akhtar for this effortless and tireless, great effort and tireless efforts for this PC1. And he
Osman, थोड़ा mic
used,
ऊपर कर.
used his personal contacts to get this PC1 approved. And I'm really grateful, sir. And we have a great blessing from Allah Almighty that we have Professor Dr. Saeed Akhtar for this technical support and his vision to eliminate hepatitis in Punjab. And second, I will, for the PC1, from the federal PC1, we have very organized system in the shape of our DHQs and THQs. We have electronic medical record system throughout from our basic health units, our tehsil headquarters, and we have all entries on our health information management system for screening, testing, and logistic management. Even it's all on electronic record system. We have very organized system, and we have developed infrastructure in last years, our basic health unit, and we are ready for any mass campaigns. We are already practicing on the union council level. We have even Punjab government has witnessed our collaboration regarding the mass screening at the judicial levels and key populations, which are the major source for the hepatitis C and B infection. And we are ready for this implementation of PC1 with the help of Professor Dr. Saeed Akhtar Saab, and we believe from the PKLI, and we will implement these inshallah in the next 10 years. And we are also spending more than 2.5 billions per year for our hepatitis C and B program so far. And inshallah, we will be, this will be a success story for us that by 2030, we will achieve the targets from the WHO. I'm really grateful.
Thank you. Dr. Atiyah, one theme that is coming out common is the communication strategy. Please remind me how much budget we have in the PC1 for the mass communication.
I will have to locate it, or maybe Dr. Hassan, if you remember how much is the amount allocated for communication strategy. As I said before, communication strategy will be for the whole of country, obviously, or that will be developed in consultation with all the provinces, and it will, Dr. Hassan, can you please help me? He's looking for it. Yeah. So, so one thing more I would like to add that once we start implementing the campaign, the program, we always have the chance to revise the PC1 as the need arises. And we at the federal level are already advocating, we are having talks, discussions with the international organizations and international donors as well. And they have committed that once the government puts in money, they will come forward and they will fill in the gaps. So there is always room. We can revise the PC1 after, say, 2 years or 3 years as the need arises. So, Dr.
So we have 528 million allocated for communication for the whole country.
No. This is public awareness. Public awareness. Right. Okay. Right. The other, Ji.
Strongly second, Dr. Atiyah, it should be a joint session for that again, face to face, like a workshop, something with the program managers to, I would say, revise it, like she said. It needs something to be changed in that PC1.
The other thing that is coming out, a common theme is coming out is that of HR. How do we tackle this in your mind? Do we do this do we let the provinces do this and not get in there, or does the PC1 have some provision of providing HR?
So HR is basically their own mandate, and they have to, for infrastructure and for HR, obviously, provinces are already running the programs. And yes, we know HR is problem not only in the hepatitis control program, but in all other programs, you can see that HR is the main problem everywhere, even in the tertiary care hospitals. Everywhere, HR is a huge problem. We are short of medical professionals, and we all know there are multiple reasons behind them. So what we can or how we can support the provinces is that we can obviously HR will be there, but we can support them by capacity building of already deployed employees, or but for as far as PC1 is concerned, for infrastructure and HR, some specified allocation has not been done.
Thank you. G, Dr. Asghar, last point, and then we will move
As
to.
far as HR is concerned, as we know, it's a very big issue in all the provinces of the Balochistan in the public sector. But what I just suggest, like in Global Fund, there's both the public and the private inside the contract-based HSR is used. So we get the results from that. I'm not asking that the whole HR should be on contract, but few key positions should be on the contract basis on good salaries for good results. This is what we have seen all my profession. Thank
Right.
you.
One last point from my side is that the other common theme is lack of the electronic medical databases, right? Punjab has one. I don't think the other three provinces have it. So I think that is something that you've also developed it. Okay, so I think there is some discrepancy there in how the things are developing. We'll open this up to questions. Ji, say sab. Mike, hai koi?
We're going to move one mic out for questions.
So to make it as a successful program, I think what we need is a centralized electronic medical record system so that the provinces, all the provinces are on the same page. You know, with that unified or standardized electronic medical record system. And we developed something at PKLI. We'll be very happy to share with Punjab. Punjab is also, we developed with the Punjab health system through, we did that at PKLI initially. And then we'll be happy to share that with all the provinces, because, but maybe our database is also not the best. So we have to. So I think one of my strongest recommendation would be that we develop a database, maybe take the existing template, perk it and make it better, and just devise a unified system. Then comes the training of people to use that, because this is just something new. So I feel that without a good electronic medical record system and good data keeping, we had nowhere. And when you go to the international NGOs, again, you know, your validity, your truthfulness to the data, I think it becomes very questionable. So I think that is a very important take home message. And they need to be helped. People who have not developed it, I think the people who have it should share with other people.
Right. Very nice point, Dr. Said. एक सिर्फ चीज कहूँगा कि one of the functions of the database should be that people on the ground should be able to respond and react to it immediately, right? Somebody missing an appointment, somebody not available at home, and so on. So immediate ek uska reaction hona chahiye. So if a central database allows that to happen, I think that will be fantastic. Any other questions from the floor before we wrap up? We are short of time. There's one.
Thank you, everyone. The one question is the basic focus on B also, or just C? I mean, that is an important question, because some of the presentations and some of the focus was only on C. I think this is one important question to all the authorities who are going to launch any program, provincial or federal. Number two, I think we have been working as an NGO or, from the Health Foundation Forum, and have been working with the Punjab program, and they are very helpful. However, I note that the general public awareness is not in the agenda. Number two, mass screening is not in the agenda. And I've heard all the program managers here, and it appears that we don't have any national screening agenda. And comparing it with the presentation of the Egyptian Dr. Imam, I noticed that that's the basic thing. We don't have any national agenda and national guidelines and national action plan and strategy. So if we work in silos, the result will be as we are today. So that's my comment.
Thank you for your comment. There was a hand back there.
Well, my question is for you, Dr. Usman, because Punjab's program is what I'm most familiar with. There's very good decentralization mechanism for treatment of both hepatitis B and C, and now primary healthcare providers are providing these services. But my question is about a very centralized mechanism for viral load testing, because the person being screened in Rawalpindi still has to send the blood sample to Lahore, and then it takes about a week, and during that time, we lose the patient to follow up. Is this the same in all other provinces as well, the centralized viral load testing?
Thank you very much, ma'am. It's my humble submission that we have a central PCR lab in the Lahore. We have capacity of 2,500 PCRs in 24 hours. And we have a central supply chain for regarding the PCR sampling. And we have 3 days lag time. When the patient gives his samples to a screening clinic, and after 3 days, a system generated report is delivered to his cell number and mobile number, and he can get it downloaded and get his treatment from the nearby treatment center. And it's 3 days lag time.
Hepatitis program has 7 molecular labs on divisional basis, 2 at Karachi, Larkana, Mirpur Khas, Hyderabad, Sakhar, and we are doing their PCR, and from other districts we transport samples there for PCR testing.
I'm just going to make a comment. There are 160 gene expert machines as we speak sitting in Punjab, but used by the TB control program. I think there is a lot of missed opportunity for linking care, and that's like a debate for, but it's an excellent point. I think even for us, PCR is the roadblock, but different mechanisms in Punjab, and I'm sure the other centers also exist to tackle that issue. Dr. Said?
Right. So I think we are out of time. This discussion could go on for another hour, I think, and also with the audience, but we need to wrap up, unfortunately. Just a couple of closing comments. I think, as the minister said, if you need to look at a program, look at the budget. So at least we now have a program where there is a well-defined budget and money. And this money will increase, because with this commitment, we will now be able to go to international donors and request additional funding. And there is that keenness to support Pakistan, as Dr. Atia suggested. So we are hoping to develop a roundtable of international funders in Islamabad around February time, sir. And we will invite, it will be sponsored by the ministry and and co-hosted by the Hepatitis Fund, which is the only fund which is now funding hepatitis activities directly. And they are the ones who will gather those sponsors and bring them to Pakistan. And we will be the ones who will be discussing what sort of funding we need. And we are very hopeful that this will happen. Second point, just second closing point, I think from the federal side with the PC1, it seems that we need to be flexible with the provinces. Because as we've heard, there are different problems, different aspects, different issues. So rather than tight jacketing them into 1 or 2 categories or 3 categories, let's be, for the first, at least for the first year of the program, let's be flexible as we can, so that we try and solve their problems on the ground and not straitjacket them into just a couple of categories. So with that, I would like to thank the whole panel, particularly Dr. Atia, because we put her on the spot quite a lot. Thank you very much, madam, and all the program managers. Thank you.
Thank you very much. I'm now going to invite Dr. Faisal Yunus to take the sessions forward. Dr. Faisal Yunus is an epidemiologist and a public health specialist. He was the Hepatitis Prevention Treatment Program Director back in 2017 to 2019. And since our funding dried out, we had to close that program, but the funding is back up and so is he. So he's going to lead us next in this session as well as in the program. Dr. Faisal Yunus.
Just for the sake of time constraints, I think we will leave the question session at the end of these, rather asking question sessions after every talk. So that will be.
Assalamu alaikum, everyone. As Dr. Amara said, I am Dr. Faisal Yunus. My background is in public health medicine and communicable disease control. I am the project director for the Hepatitis Prevention and Treatment Program, which is the outreach program of the PKLI. And I'm also leading on the PKLI filter clinics, which are in the process of setting up as we speak. So I'm just mindful of the time. I would request all the speakers to please limit their talk to about 15 minutes or so that we are able to wrap up the session and move on to the lunch break. It's my absolute pleasure to first welcome Dr. Asad Chaudhry. He is the president of Pakistan Society of Hepatology. He is a consultant gastroenterologist and hepatologist, director of the PARSA Eco Program Pakistan, and he is very active in microelimination, HCP microelimination programs in Punjab. So, and he will be speaking about strengthening the HCV elimination public-private alliances. Dr. Asad, over to you, please.
Thank you. Thank you very much. Bismillahirrahmanirrahim. Assalamu alaikum to everybody. It's an honor to be here. I really thank organizers for inviting me to this meeting. I will bring a different perspective. You have seen a lot of things you have, but just to give you my background, I am a private person, private partner, rather in terms of public-private partnership. Since 2006, I've been working with various NGOs, philanthropy organizations. You can see Health Foundation, PARSA Trust. And I did it for 15 years, I think. In the past 3 or 4 years, I've been engaged with the government projects. I'm really thankful to the Hepatitis Control Program Punjab for taking us in their envelope. And you have to... How do I move the slides? I'm sorry. So I'm really thankful to the government. And since then, I realized what I've missed and what I did not miss. Forward, So the experience, I think if I hadn't worked solely in the private sector, I wouldn't have learned my lessons. And now when I work in tandem with the Hepatitis Control Program. So that's the ray of hope or the light that I really see what we can do collectively. So I bring my greetings from Gujranwala. If you, Maharaja Ranjit Singh, the clock tower, and you know, so if you're more than welcome. I have not seen the chiras and the barbecues of Gujranwala. So what I'm going to go through is going through the current healthcare provision in Pakistan, basically some data from the national health accounts, local data from the private sector about micro-elimination, the partnership or alliance, how to make it work, and what expectation we have. We have all seen this slide. I'm not going to spend time on this. With eliminating hepatitis, fulfilling the WHO goals, what difference we can make. So this is that you can see the share of the private sector in health in Pakistan. Nearly 60% is the private sector, and the public sector and others is 40%. Of this share of the private sector, approximately 90% is the out-of-pocket health expenditure in Pakistan. So here the big chunk is the private households out-of-pocket payment. Then you can see the private health insurance, which is probably 2%, and then NGOs, which share 10%. And this is the breakup of the over-the-pocket expenditures of private households by category. In where you can see transportation costs, the Parchi fee, doctor fee, medicine, diagnostics, tips are also included in here. So it's a pretty detailed breakup of Pakistan and various provinces. This is from my city, and this has been discussed. 80% of the people are affected with hepatitis C in 20 to 50, is between 20 to 50 years of age. Just to briefly share some data from our satellite clinics of 5 centers in Gujranwala, Gakhad, Garjak, and Kila Didar Singh, where we screen nearly 11,000 people. And of the seropositive hepatitis C, nearly 2,400 patients, only 900 patients, they came for further follow-up. This is despite they were told it's a free or subsidized treatment. We will help them with PCR. We weren't working with the hepatitis control program at that time. An antiviral was recommended in 706 out of those, and if you see from the total, only 25% actually they were linked to the treatment. Then we had this data presented in American College of Gastroenterology, and you can see the financial issues. They were hindering this linkage to care, cost of treatment, absenteeism from work. Remember, in Punjab, ye dihadidar log hain, they are daily wagers. If they miss one day, that means no meal for the family for that night. So we have to keep this. Transport was an issue. Fear of side effects was still there. And this is the era of DAA. And 16% they prefer non-medical therapy, and 56% were not aware of the disease. Then we moved on to another area, Varpal Chatta. It is about 45 minutes drive from Gujranwala. That's an affluent village, metal road, about 400-meter high street. We aimed at screening 10,000 population, and we targeted screening all above 13. It was a fully funded project. And we had a very poor turnout. We stayed there for 5 days, for about from 9 to 5 and sometimes later, and only 800 patients, they came out for screening. Just to give you an example, when I was sitting with the village elders at that time, the imam of the mosque, he was sitting besides me, and he was just backing everything that I was saying, but he didn't get himself tested. So the female, they were so resistant to testing because for the fear of rejected by their husbands. So we tried everything, and then we published this. What were the factors which decreased the compliance? You can see education, primary or less, was more than 50%. Only 15% were salary based in this population. Awareness of the disease was reasonable. Factors preventing were more or less the same. And this is about that's the reason what the female population gave us from this village. So poor compliance with screening and subsequent treatment due to financial, logistic, and social reasons, along with the lack of awareness of the nature of the hepatitis C and its potential complications. That's what we concluded. This is another study which was funded by Gilead Sciences, and where contextual and individual factors associated with knowledge, awareness, and attitude on liver disease. It's a large-scale Asian study done in 11 countries. And this is the data from the educated lot. We reached out to 500 people. It's an online survey, mostly graduates and above. Sorry. So here you can see there are still people who believe that hepatitis C can be prevented by vaccination. I'm not going to go into a detail. Knowledge wasn't bad. The knowledge about transmission of infection was okay, but there are certain myths. Only 4 in 10 knew that viral hepatitis B and C is not transmitted through mosquito bites or by dining together with an infected person. And only 2 in 10 knew viral hepatitis B and C is not transmitted through fecal or oral route, usually through contaminated food or by eating contaminated raw seafood. So most of the people, they were aware about hepatitis. And here you can see I'm just focused on hepatitis C here. 57% they said C is a bacterial infection. 50% knew it's a viral infection. 80% felt it can be prevented by vaccination. 30% thought it's airborne. And then there are other hereditary but generally. So this is another thing. It's about the stigma that there are 2 in 10 people who were extremely unlikely to have dinner with or work together or get married to someone diagnosed with hepatitis. And the top 3 ways of reviewing disease information in Pakistan is doctor consultation, internet forum, and internet search. And here you can see how do the people in Pakistan, they are seeking 5 in 10 people, they sought medical treatment at medical specialists for treatment of any liver disease, which include the specialist gastroenterologist, private general practitioner around 40%, government-run clinic around 38%. And one thing that really puzzled me, that this is a Pakistan-specific question that actually I suggested to put on. Nearly 50% of the people, this segment was aware of the government-run programs. They were unaware that the hepatitis B vaccination is available free of cost in Pakistan. And I think in Punjab and in Sindh, I mean, everywhere, they were not aware of that. So micro-elimination, we know we have to find the missing millions, link them to cover. Then we went into this project in Garjak, and we just focused on 4 streets of 2,400 population, engaged local community, messages were disseminated, mosques were involved, people were used to, to encourage people to come forward for screening. And that's the algorithm we used. If the APRI was less than 1, that's what we use at. It was 2019, I think 2018 at that time. We gave them soft tech for 3 months, no on-treatment monitoring, and just got SVR. So here you can see of the population targeted 2,300, we managed to screen around 1,400. Out of these, 202 were seropositive. We got PCR sample on 189, 119, 63% were viremic. And out of 119, we were able to start treatment on 100 of them, which is 84% people who were put on treatment. 89% completed the treatment, and the SVR was 95. It's a fully funded project with a very strong local area support. We involved the NAZM and the local people there. And alhamdulillah, we got very good results. So just that's about, we published this in American ASLD. So what does this involve? We need a screening camp, and there's all the things in the screening camps. I'm not going to go into detail. We did mention, because in Punjab, we have to get connected to the portal about, and with the staff and the Wi-Fi connectivity. Filtering out the previously treated is an issue. PCR sampling, collection, handling, because we collect the PCR sample there and then. And we have a strong, so we don't let them go away. We just collect the PCR sample. And then those who are viremic positive, through the local area person, we get the CBC, LFT, and creatinine done for further. Follow-up of the positives, catch-up vaccination, spreading awareness. As a private partner, an NGO can provide premises, staff, basic funding, basic labs. They have this local area influence and knowledge base, and they really get after the people who are positive. So they look at enhancing their profile, and this is if they work, they will get more donor, more philanthropy, and of course, patient confidence. And one positive side effects, when they are engaged in hepatitis, it will definitely reduce spread of infection. Because these organizations, they are not only merely treating hepatitis alone. So as a public partner, we have screening kit, PCR lab, antivirals, an auditing and monitoring system, which works very good. So these are the things, as a public-private alliance, and how can we link? And I'm very strong believer of linking both of them, the public partner and the private partner, through this ECHO, where we move knowledge instead of patients and provider. And we, as a PARSA ECHO Pakistan, we working towards goal of develop capacity to safely and effectively treat hepatitis C in all areas of Punjab and monitoring outcomes. This is the ABCD, where We use technology to leverage scarce resources, share best practices, case-based learning, and a web-based database. And this is how it will work. If we have a PARSA ECHO or PKLI involved, we train doctors and community health workers, and then that will amplify the response to cure the patients with hepatitis. Let's not forget the primary care physician. We have to think about them. They are there. They are very important stakeholders. We have to find ways to engage them, to train them, incentivize them, and monitor them. And I think we can reach those areas where probably it will take years to reach down. Just it's a list of clinics that we were doing, and there were some centers they were treating hepatitis before, but there's adult centers they were not treating. The one in Gakhar, Hafizabad, there's a village called Kot Ishaq, Okara, and the other clinics. These are the people, when they were linked with ECHO, they started treating, and this is the data that I got from, and they have excellent SPR. And when we work, this is the slide I showed you. And this is what I'm looking at, out-of-pocket health expenditure. I'm not making, any a very strong assumption here, but transport cost, doctor fee, medicine, diagnostic, this is 75% of the out-of-pocket healthcare. So if we really work together, we can reduce the impact, because everything cannot be done by the government alone. And let's reduce the pie of the out-of-pocket health share. So these are the treatment rates in Pakistan. You can see over the years, we spiked in 2017, 2018. This includes both public and private market. We need to treat 880, possibly minimum compromise is 525,000. And 2022, I have a figure of 188,000 here. This is the last slide. So I rest my case with you. And I think we have to move forward. The solution is out of the box. We all have to join hands. And with a strong public-private alliance, let's take treatment to the people. Thank you very much.
Thank you very much, Dr. Asad. This is really awesome presentation. So as we are starting with our own program at the PKLI, I'll be touching base with you shortly on that, inshallah. Right, moving on, and we'll have the questions at the end of this session. So our next speaker is Dr. Usman Ali Khan. He is the Deputy Director of the Hepatitis Control Program at the Primary and Secondary Healthcare Department of the Government of Punjab. And he'll be speaking about micro-elimination project in Punjab, and can and should it be expanded.
Bismillahirrahmanirrahim. I'm really grateful. This is the program overview and micro-elimination project, which we, with the collaboration of the WHO, we have operationalized in district Nankana and in one union council Manama. And next, please. This is the brief program overview. Next slide, please. This is a brief history of our hepatitis and infection control program from 2005 and after devolution, and now it's in non-development mode. And we have approved our SNEs from the finance department. This is the general disease burden of hepatitis B and C, and we have prevalence of 8.9% hepatitis C and 2.2 in hepatitis B. This is our basic infrastructure. We have hepatitis clinics in 26 district headquarter hospitals and tehsil headquarter level hospitals. We have 122, and one from PKLI. We have 60 RSC, developed RSC hepatitis clinics and 4 dispensaries. We have public-private partnerships with 5 NGOs. And we have 217 clinics in all over Punjab. We have also assisting the 23 hepatitis clinics at our tertiary care hospitals. We have the state-of-the-art PCR lab with 2,500 capacity of tests per day. So far, we have hepatitis and infection control program conducted more than 9 lakh PCRs from 2018. And we have treated 5,30,430 persons with hepatitis C infection. This is our real-time data, and to access the stakeholders, we have this picture of the dashboard. We have 29 lakhs, as we have stated that we have screened 29 lakh persons, and we have treated this person. This dashboard is, and this system is access to all district headquarters hospitals and tehsil headquarters hospital. And we are now scaling up and giving the source or access to this dashboard to our rural health centers and basic health unit for the electronic medical record. And this is our elimination targets by the WHO. We have the micro elimination project of in Nankana Sahab district with collaboration of the WHO. These were the guiding principles with the capacity building of the staff deputed at the RSC level and BHU level regarding the screening, testing, treatment, and the behavioral change communication at the basic health unit and unit council levels. We have well-designed intersectorial coordination with local NGOs. We have linkages with partnership with development partner at community level. And we have also engaged the private sector, private clinics, quacks, and other homeopathics for the screening of the hepatitis C and B in this unit council. To establish, there were two objectives. One for the comprehensive community-based approach to educate, prevent, test, and treat chronic hepatitis B and C infection. And second was to demonstrate the feasibility and effectiveness of this approach. We have adopted the methodology regarding the education and community awareness through the school health nutrition supervisors and our lady health workers and our other medical staff deputed at the unit council level. Then we have population level testing and village and BHU after micro plans and mapping the community. Then we have the comprehensive preventive intervention. We have the blood safety, injection safety, infection control, hospital waste management, hepatitis B, and one for more, we are also operationalizing the infection control program. We have 27 incinerators at our district level, and we are collecting almost 4,500 infectious waste from our hospitals, which is centrally incinerated at our incinerator sites. And we have a centralized registration for the barbers and beauty salons for our Punjab, which are the main source for the hepatitis infection. The total population of the demography of the district Nankana was 1,39,000 and the target population was 19,000. We have decentralized assessment and treatment at 6 rural health centers, 2 tehsil headquarter hospitals, and 1 DHQs for this project. And we have trained the doctor, nurses, and paramedics for this mass screening campaign in district Nankana. We have linked this data to the provisional dashboard, and all these data is still present on our dashboard for this project. And we have comprehensive preventive interventions regarding the blood safety, injection safety, as explained, that the community was sensitized regarding the source of infection and spread for the hepatitis C and B in the community. And this was our implementation. And this project represents a partnership between the Nankana Sahib district team and the Punjab Hepatitis Prevention and Infection Control Program, and supported by the WHO headquarter and regional and country office. Then we implemented through building the existing community networks, our district monitoring and evaluation teams, tehsil monitoring and evaluation campaigns teams, and our unit council level monitoring and evaluation committees were there to access this project and supervise all the activities. We have 3 phases. In first phase, in 3 weeks, we have mapped the villages, we have mapped the unit council and important key points. Then we have the piloting it in single tehsil, and next 6 months, then phase 3 we will scaling up to other provinces. These were the stats of the main projects. We have screened 17,000 in that unit council, and then it was positivity of 11% in hepatitis C at 1,927 were positive in that unit council. And these were samples were taken and treatment was given to the respective positive cases. And it can be replicated to the district and provincial level and can be scaled up through the Prime Minister Hepatitis C Elimination Program. We have already, I have told that we have experience regarding the mass screening. We have infrastructure and HR available for this mass screening on war footings. We have recently our Minister Primary and Secondary Healthcare also initiated local hepatitis elimination prevention in district Rawalpindi in 6 unit council, replica of this campaign. the task force, with the help of the task force for the global health and global health hepatitis elimination project. I'm really grateful. Thank you. Any questions?
Thank you very much, Dr. Usman. So our next speaker is Dr. Amara Naweed. She is a US trained consultant gastroenterologist and hepatologist. She was the clinical director of the hepatitis prevention and treatment program here at the PKLI until about 2 years ago. And she'll be speaking about the lessons which we learned from our HPTP program. Over to you, Dr. Amara.
Okay. We're just going to talk about kind of what we did in the 2 years that we had. We had clinics from March 2017 up until July 2019. And so we're going to take you through kind of the things that we did. The objectives of my talk are going to be, talk about the setup that we had, the success and challenges and kind of the lessons learned. And now that we get our clinics, what are we going to do differently? I'm just going to quickly talk about it. There's a lot of healthcare professionals, especially nursing staff that's sitting at the back. There is community healthcare risk factors, but there are major healthcare risk factors. Before you talk about a barber yourself, please look at kind of what we're doing, our community is doing. WHO has identified 3 major areas for Hep C prevention in Pakistan: reuse of syringes, improper sterilization of invasive medical equipment, and then transfusion of unscreened blood. So, majority of this prevention onus is on us and not on the community. So I think that is kind of one thing that needs to be a takeaway. This is just for everybody who is not, into Hep C talks about kind of the scope that we're dealing with. So Egypt, Dr. Mamouki talked about 6.8 million people, number of exposed. Uzbekistan is doing a project, 4.5 million exposed. India, our next door neighbor, though a huge population, but not a huge number of prevalence, so 0.7 million. Whereas Pakistan, we have 11 million people, give or take, that are exposed, that need to be found and put on treatment. So a huge task. This was a slide that was already showed. You see on the left-hand side, infected and then diagnosed, treated, and cured. The orange bar is people who are infected, and kind of see how when you talk about diagnosed or found, the bar just goes down to close to 1%. So that's something that we have to work on. In 2017, we were given a budget by the government of Punjab. We were given, give or take 1 billion rupees, if I remember correctly. What we did were we set up, through the government of Punjab, we took over some hepatitis prevention treatment clinics that they were running. We took 24 clinics all across Punjab with center in Lahore that was kind of running the whole operations through medical officers, which were primary care physicians, but were being led by a hepatologist in the center. The services that were being provided at the HPTC clinics, as we call them, hepatitis prevention treatment clinics, was screening of hepatitis B and C, vaccination against hepatitis B, counseling on risk factor assessment, lab testing, ELISA and PCR was being offered, treatment with the latest medications. We started with soft Riba, our journey, then we went to soft DAC, and now obviously we have soft Velpa. Referral was made to a PKLI hospital in a very organized fashion. So patients were screened. If anybody had advanced fibrosis, cirrhosis, decompensated liver disease, only those patients were, referred forward. And we did a lot of health education campaigns and awareness. I think, as you've heard from all these programs, others as well, that was kind of one of the main important things needed. And then patient feedback was reported to kind of improve the system. In Lahore, the additional things that we had was an ultrasound, fibroscan. We had access to liver biopsy, endoscopy unit. We had psychiatrist support services on site as well as nutrition and diabetes. And I think these services really helped the patients in Lahore. The organogram of each individual HPTC was such that it was led by a senior medical officer, again, a primary care physician. There was an admin assistant, staff nurses, pharmacist, receptionist, medical officer, phlebotomist, and kind of some ancillary staff. So 11 people in total in each clinic. The clinic setup had dedicated medical officers, like I said, which spent 2 weeks of training on site. And I'm going to talk about this a little bit more. Clinic operations ran from 9 a.m. to 5 p.m. There was a WhatsApp group for their support. And we had an electronic medical record that was purpose built. So anybody sitting in Lahore could access data, in Okada or some other remote sites. And there was, live interaction. The one of issues that we had was we had centralized testing. This is something that's already been addressed. So our samples after a Hep C antibody test were brought to Lahore for confirmation testing. These are pictures of people who came in for 2 weeks immersion in Lahore. So it was a 2-day workshop followed by didactics and then on-site supervision. We had these people examine patients in front of us, do interactions, practice EMR. We just did not bring in medical professionals or like physicians, I may say. We actually brought in the nursing staff, the phlebotomist, the administration. The whole team was brought in and given an immersion. And I think that really helped, put in excellence in the center. And what we did in the last 2 days of the immersion was that the teams, each team that was supposed to go out actually worked like a team in the center Lahore, kind of saw the patient operations in Lahore, and troubleshooted, and they were given, advice and, feedback from the people in center who were kind of working with them. So that also worked out really well. We created simplified testing and treatment guidelines. As we heard, that was very important. So we actually created guidelines for hepatitis C and co-infection patients as well. So we created hepatitis B guidelines and HDV guidelines as well. South Punjab, a huge HDV population. The prevalence survey that we did says 17% of Hep B patients are actually infected with HDV. So I think as we talk about HBV in all these conferences, I think we cannot ignore the burden of HDV. There was a real-time consultant via support hotline. This is Dr. Osama Tariq Bhatt, one of our consultants, hepatologist. So with the EMR that we created, we had provided a 24-hour hotline to these consultants, so everybody could actually call in. The consultant had on-site access to EMR. If he couldn't understand something, he was able to kind of look at the charts and figure out and give them feedback in real time. WhatsApp is very popular in Pakistan, so we actually created a WhatsApp group for our medical officers as well. And some of the best things was it was easy, quick access. Sometimes when you couldn't understand something, especially rashes, especially in the era of ribavirin, you could actually look at the rash and then guide accordingly. So, this is a picture where we were given a rash and information to kind of respond on it. The one thing that was very good from these WhatsApp groups was that, we saw emergence of group leaders. So we initially were very responsive. And then as we became more occupied, our response time kind of slowed down, but we saw leaders, which were primary care physicians, emerging from this group and responding very appropriately. So the group actually just needed counseling or, direction or redirection in one way, but really didn't, they could handle basic things on their own. And the other thing is, people who are in the periphery have challenges that I think us in the center cannot understand. So what happened was they kind of shared their experiences. If somebody was having an issue and put a question on the WhatsApp group, I in the center probably would not have responded more appropriately, but people in the periphery responded very appropriately and kind of developed referral networks, which I think was something that was very incredible. You've heard about Project ECHO from Dr. Asad Bashir, sorry, not Asad Bashir, from Dr. Asad Chaudhry. We actually did an ECHO program, with these medical officers as well, and it was kind of very successful. This is Dr. Arif Siddiqui sitting in one of our sessions. So what we tried at best was to minimize the time frame for testing to treatment. Like we've heard, there's a lot of loss to follow up. What we did was we registered these patients. We did same-day point-of-care testing for Hep C and Hep B, and there was a 20-minute turnaround time. Those who were found positive underwent further testing for, staging purposes. So they checked, they got a CBC, LFT, creatinine, and HCV or HBV PCR testing, whatever was most appropriate. Those that were negative were vaccinated for HBV and sent on their way. So on the second visit, when these patients came in, we already had an APRI for these patients, and we were able to start these patients on treatment at their second visit. This is what, one of the people was mentioning. The wait times between PCR can be significant. You're talking about bringing in hundreds, or even maybe 1,000 sample a day to the center. And if you have like the slightest of thing that breaks down in this chain, backlogs develop. And so initially we started and we were very happy. 2 weeks wait time, we thought back then wasn't that much because we were a new program, but then our wait times went up to as high as 3 months. The one more important thing was that, when we did point of care testing, I thought everybody who had a point of care testing would be linked to at least, a PCR or a BC, even if they didn't come back for results. But interestingly, 20% of the Hep C antibody positive patients did not come back for PCR testing. I thought this was a lack or, bad thing on our program, but there's recent data from Canada showing the exact same thing. They have IV drug users or other patient populations that will not wait that 20 minutes to get their results and be put on treatment. There's hesitation, there's anxiety. And so while 20 minutes may not seem so long, is actually a long time. And I think there's new work on kind of decreasing this Hep C time frame so that you can actually, there's just like rapid kits, there's 1 minute or 5 minute Hep C testing strategies now becoming available. So this is kind of, our Hep C cascade of care between March 2017 and June 2019. 24 sites, average 19 months of operations, before our program lost its funding. We were able to register somewhere close to 300,000 patients. We tested somewhere around 120,000 patients. I think close to 80,000 patients were found to be PCR positive, and we were able to put close to 60,000 patients on treatment. This is comparison of what we did in the center compared to what happened in Okara, which is a site that is 80 miles away from here. So, what I want you to focus on is the SVR rates, so if people, and this is something that's already been proven, SVR rate in Lahore, 97.2, in Okara, a little bit better, even 98.8. And, when Project Echo was launched, that is kind of what they saw as well. If people are treated in their, peripheries, closer to their primary care physicians, compliance rates are actually higher. So, and this is back in the interferon era when Project Echo was launched. Interferon is a very difficult medication, very difficult for a primary care physician to manage. But Project Echo was able to guide these primary care physicians in the use of interferon and actually showed a much better SVR rate because of adherence to the interferon regimen. Some of the hurdles that we faced were sheer volumes. Pakistan is a huge population. When you announce free testing and treatment, everybody comes to your doorstep. And I think that's, something that every free testing site in Pakistan is going to face. Sheer volumes resulted in increased patient wait times. Like I mentioned, we had a centralized PCR testing system that resulted in significant backlogs. We tried our best, but didn't have a very strong reminder system for patient refills, and follow-ups were loosely documented. Non-compliance was also something that I think was loosely documented and needs to be looked at in a better way. And then reinfection for high-risk population. And this is why I specifically wanted this talk on reinfection. Who's high risk in Pakistan? Every single Pakistani, I think, is high risk in Pakistan. Everybody goes to a dentist, everybody gets an injection. So when you talk about Hep C, yes, we talk about IV drug users, but for me, every single Pakistani is at high risk for Hep C. When you talk about tackling challenges, what we tried to do was we realized the sheer burden. We realized this, lack of HR that everybody talks about, especially in the panel discussion. And so, you have people out there. You don't need to depend on a trained hepatologist to do this. You don't need to depend even on a primary care physician. Your nursing staff can be your first line and, guide and triage patients appropriately. So that's what we did. This is one of our nurses sitting in at the front of our triage desk. So what we did was we had trained RNs who triaged up patients. Everybody was getting screened. So what they did was anybody who was antibody positive was ordered a PCR and CBC LFT and provided education by our nurse. If they were Hep C antibody positive, PCR negative, they were referred to the appropriate physician for counseling and testing. If they were Hep C antibody negative, they were just given a vaccine for Hep B, screened, counseled, and sent out, and were not seen a primary care physician, which I think is very appropriate. Not everybody coming in for screenings needs to be seen by a primary care physician. I think nurses can handle that. We thought Hep B being difficult, we didn't add Hep B to our nurse triaging pathway. And so everybody who came in with a positive Hep B test was actually referred to the physician. This particular thing I'm going to address on its own because I think it is something that is overlooked, or the importance of it is not kind of recognized. Concept of pharmacy refills does not exist in Pakistan. So in the US, you call in a prescription, you say, I want to give my patient SOF and Velpa, give it to him for 1 month and give him 3 refills. coming from a government setup or a government funded program, we're not handing out 3 months of medication because that's too expensive. When somebody comes in, pharmacy is not authorized in majority of these places to kind of refill those medications. So these patients are just coming back to the physicians and kind of overwhelming the system. So I think that is something that really needs to be addressed. If you've identified a patient, he's been put on treatment, he doesn't need to come back to the physician. These drugs are now proven to be safe and effective. So all you have to do, is have the pharmacy person ask a set of questions and then just refill the medication. This refill system is being utilized all across the world, I think, except for Pakistan. Some of the issues we had with our WhatsApp group, there's a love-hate relationship I have with WhatsApp and, groups. Messages can sometimes get ignored if you are really busy. And if you have somebody kind of asking a question, they're shy about it themselves, you can snub them and they would never ask a question again. Sometimes people post irrelevant messages, political messages, XYZ. And sometimes, you have physicians who are not so trained kind of disseminating false knowledge. So I think you have to be very vigilant about these WhatsApp groups as well, and they have to be strictly policied and monitored. I'm bringing this HCV cascade of care back into the picture because what I want to do is I want you to see these percentages that I didn't talk about now, because this is what the Hep C cascade of care is. And when people talk about finding the missing millions, technically we saw 300,000 patients, but we treated only 60% and somebody or 60,000, and somebody might say, well, that's not good. You were given so much funding, but you only ended up treating 60,000. But anybody that we diagnosed, out of those we diagnosed, 90% were put on treatment. So I think that is the challenge with the Hep C cascade of care. There's so many people, by the time you start searching them and treating them, a lot of your funding goes into finding the person that you want to screen or you want to treat. And that's what we've seen here as well. We have to find 4 Hep C antibody positive patients to find 1 PCR positive to be put on treatment. So I think this cascade of care should not be ignored. This is kind of registration treatment site-wise. So these were our 24 sites. I want you to see percentage of registered treated. So Lahore site, which was a huge site run by a hepatologist, 22% registered got treated, and across kind of it was similar things. And this is not a poor reflection of our program or any program out there. I think this is what people have to understand. I think screening cannot happen at centralized sites. And I think it's very nice and important to talk about, creating these hepatitis treatment clinics. But I think we have to understand that, if basics is also done at these clinics and at these sites, the system is going to get overwhelmed and you're not really going to treat a lot of people. You might screen them, but you're going to have trouble linking them to care. So I think that is why we're trying to come up with a program where screening is happening in the periphery and only appropriate people are brought into these treatment centers to be treated, and counseled appropriately, and then, staged and linked to, if they need HCC surveillance, to other higher treatment modalities. This is just one slide that I wanted to put in. You talked about Punjab, and we looked at the hepatitis control program Punjab, and we are talking about PKLI. And this is the data that I have from 2019. Then COVID happened, and I think we're still struggling from unified data. But despite massive efforts in Punjab, when I gathered my data and combined it with the hepatitis control treatment program, only 120,000 patients were treated in that year in 2019. And this was like the highest successful year for Punjab for Hep C treatments. So I think that is something that we have to appreciate. When you look at data, or Punjab has to treat 400,000 patients per year to meet HCV elimination targets. So I think it's, buzzwords are good, but I think the reality is unless we really step up our game, we're going to have issues. Centralized PCR testing, biggest issue. System has a lot of overlaps, like our patients are going to go to hepatitis control program, then back to us. So I think as we're talking about, creating a centralized system for the government, I think it's also important for private entities to have kind of linkage as well. Because a person, like somebody said, might come to the government sector for testing, but might go somewhere else for treatment. So for that particular patient, you might think it's a loss to follow up, but that patient has actually been treated somewhere else. The one other thing is, we're offering free treatments, and treatment is expensive. So, a lot of patients are now coming all into the government setup. So I think if we really want free treatments, then we really have to understand that, we really have to provide a lot of funding, because those who can potentially buy their own medicines because of cost savings might want to come to the government setups for free testing and treatment. This is the site that I was initially talking about when Dr. Imam Wakid was here, we are getting back 24 districts. We mapped out, we have 52 million people, in those districts. So if we really have to screen everyone in that district, talk about elimination, at least in these districts, we're talking about 7.4 million screenings per year. And you can look at the cost associated with just screening. We talked about the PC1, how much funding we have. I'm not talking about national funding or, national or the cost of national screening. I'm just talking about the 24 sites in the districts that we have to capture. So 11 billion cost if we have to screen everybody, and this is point of care testing, and 1.6 billion per year just for screening. So just some numbers to keep in mind. And this is my last slide. This is where I'm going to stop. I was recently in Paris in the hepatitis summit, and I think this was one thing that was brought out by the Australian person, stakeholders in National Point of Care Testing Program. You see the screen is full. We all have to come together. I think if somebody thinks they can do it alone, they cannot. I think we all have to come together, have a unified strategy, and kind of then make the progress towards elimination. Thank you.
Thank you, Dr. Mara. Right, moving on swiftly. It's my honor to now introduce our next speaker, Dr. Saeed Hamid. He's a professor of medicine and consultant gastroenterologist at the Aga Khan University Hospital, Karachi. He's a member of technical advisory group at Federal Ministry of Health and also chairs WHO Hepatitis C Guidelines Development Group. And he'll be discussing enhancing linkage to the care for effective HCV treatment. So.
Thank you very much, sir. And let me start by appreciating and thanking the hierarchy of the leadership of PKLI for organizing not just this symposium, but also yesterday's very important public announcement session that I think I don't think, but I'm sure will be the catalyst for change as we move along. A special thank you to Amara, whose energy hasn't diminished even one little bit after all this time. So I will need to ask her what she eats in her as an energizer. So my task is to talk about simplified service delivery, enhancing linkage to care for effective HCV treatment. Philippa Easterbrook is online. She is the champion of simplified service delivery. I'm going to be using some of her slides, so I hope that she does not mind that. So before we talk about simplified service delivery, we need to talk about simplified guidelines. Without the simplified guidelines, you cannot have simplified delivery simply. And what has happened at the DHO, at the WHO, and it has been my distinct honor and pleasure that for the last 3 iterations of the hepatitis C guidelines, I've been asked to chair the guidelines group 2016, 2018, and 2022. As you can see very quickly that we have moved from treat all, who to treat all, no genotyping, DAAs preferred, pediatric formulations coming in, with the age of treatment going down, and then this idea of decentralization, integration, and task shifting, which are the components of the simplified health service delivery. And then what is coming are different ways to test and screen. For example, there is active work going on HCV self-testing, point of care NAT assays, reflex NAT testing, et cetera, et cetera. So we have come a long way in trying to simplify the HCV guidelines. And now we are working on trying to develop the same simplified guidelines for hepatitis B. And the reason is very clear that Hep C, I think since the guidelines have been simplified, these are global figures, 23% have been screened, 16% or sorry, 13% have at least been linked to treatment. These are 2019 figures, and these are global figures. Whereas if you look at hepatitis B, it is really bad. Only 10% have been screened out of a possible 296 million people, and only 2% have been put on treatment. So there is a need for hepatitis B guidelines to be simplified. And we have now got a guidelines development group, which again, it is my pleasure and privilege to be co-chairing with Dr. Wendy Spearman. These guidelines will come out towards the end of the year. We were hoping to produce these by the World Hepatitis Day, but time was very short and the WHO processes are quite long. So hopefully by November, we should have these guidelines available to us. So what does simplified service delivery mean? These are the key definitions. So 3 things: decentralization of services, as we've just heard from Amara, going from the hub to the spokes. And this refers to delivery at peripheral health centers, community-based venues, locations beyond hospital service sites, bringing care nearer to the patient's homes. Coupled with this are integrated service deliveries. So wherever you can, you may be able to integrate these service deliveries. For example, in HIV populations, you can integrate HIV care and hepatitis C care, or hepatitis C and hepatitis B care, for example. Task sharing is the other methodology for simplified delivery, which means that there is a strategic redistribution of tasks among healthcare workforce teams, and the specific tasks are moved, shared, and delegated. So it is no longer the mandate of the practicing hepatologist in the hospital or big centers to treat these patients, but elsewhere. And there are a number of colleagues who are sitting there, and I'm sure, at least in my clinic, I'm now seeing less and less new Hep C patients that need treatment. So they're being generally treated outside, and we are seeing the ones where there may be problems, for example, a relapse or something. So therefore, in the 2022 WHO recommendations, we did recommend very strongly, and this is a strong recommendation, that there should be decentralization, there should be, if possible, there should be integration, and there should be task sharing. And the task sharing specifically, I want you to read: we recommend delivery of HCV testing, care, and treatment by trained non-specialist doctors and nurses to expand access to diagnosis, care, and treatment. This nurses part is extremely important, as is the non-specialist doctor. And to remind you again, these are strong, all of these are strong recommendations with good evidence behind them. So this is the evidence. This is a paper developed by Philippa Easterbrook as a senior author, and it looks at full decentralization, partial decentralization, and no decentralization. Full decentralization would mean that everything happens at the patient's, literally at the patient's doorstep, or within arm lengths of the patient, where the patient lives. Partial decentralization would be something that, for example, Amara talked about, that there is a screening mechanism, and then a sample is sent remotely to another site or another center, for example, to Lahore for testing, which takes a couple of weeks, and then treatment is offered when those samples come back. And no decentralization, of course, means that people are referred. Anybody who's HCV positive are referred to a specialized center, which happens less and less. And sorry, as you can see in this forest plot, there is absolutely full decentralization, and this is looking at linkage to treatment. So linkage to treatment with full decentralization is absolutely the right thing to do, whereas even partial decentralization is not moving beyond this zero effect line. So it has to be full decentralization to try and capture the maximum benefit. So what is the evidence? 142 studies from 33 countries, increased uptake of HCV viral load testing, linkage to care and treatment among people who inject drugs, comparable SVR12 cure rates between specialists and non-specialists. And this was even shown in the first ECHO paper, which was dealing with interferon therapy. So remotely interferon therapy given by non-specialists was almost equal. In fact, it was actually better than the University of New Mexico Center, which had a slightly lower cure rate as compared to the non-specialist doctor. And there is acceptability by the end users. Many surveys show strong support for fully decentralized and integrated HCV services. And this also is important because there is a non-judgmental, non-stigmatizing approach among healthcare workers generally who are dealing with these people in their homes and not in big centers. So all the more reason to do this. This we've already covered. So this is further data of decentralization and integration. These are some special groups among PIVIDs, full decentralization, and these are hard to treat groups, PIVIDs and prisoners. Full decentralization integration, 98% of them are cured. Partial decentralization, 81%. And if there is no decentralization, this is down to 60%. DA uptake treatment is 73% of at least of the people that are into the program. With no decentralization, 35%. People in prisons, full decentralization, they get into the care pathways, 94%, no decentralization, 72%. For the general population, for all populations, the SVR rate was more than 95% for all levels of decentralization. And we have very good backup data from the HIV world. And this is something obviously not like HCV, which is curable, but certainly is something like HBV, which requires long-term treatment. And decentralization has been a key factor in the successful global scale-up of diagnosis, treatment, and follow-up of patients. And we know that now the death rates from HIV are really tremendously low because this has happened. Now coming to task sharing, and this again was a strong recommendation in our 2022 WHO guidelines. With moderate certainty of evidence, we recommend delivery of HCV testing, care, and treatment by trained non-specialists and nurses to expand the access to treatment and care. And what is a summary of evidence? So this is, I'm sorry, this is small print, but you can, let me just tell you that the SVR rates are significantly higher. The linkage to care is significantly higher. And there is, again, a lot of additional supporting evidence from the HIV literature, which strengthens this notion. Now, we were just talking to Dr. Saeed Akhtar. Will our nursing council allow this to happen? And that is something that we may need to think about when we move forward. Certainly, these are well-trained nurses. These are excellent, well-educated people who can move this program through and with great success, as can be seen here. Finally, there's the concept of differentiated care. And I think that needs to be remembered. I think everybody who's doing decentralized servicing needs to consider differentiated care. And that is, where do you treat who and where do you treat what? And that is important, I think, to also to train people into this. So clinically well and stable, you need a standard care package, counseling, adherence support, treatment initiation, monitoring. It could be anywhere. It could be primary care, community-based setting, mobile outreach, physician, or nurse. But then you will get some people, maybe about 20 to 25 to even 30%, who have advanced liver disease or serious comorbidities. They may even be presenting with hepatocellular cancer, or they have previous treatment failures. They will require more intensive clinical support and follow-up, and they will be the ones who will need to be referred to a facility-based hospital, and a physician will need to see them. In addition, there may be other additional issues. For example, mental health issues in PIVIDs and alcohol abuse, migrants, adolescents who require more than the hepatitis care. In addition, psychological support, for example, and intercultural and language support and so on. And here again, this could be facility-based or community-based or even a harm reduction site. So differentiated care, again, is an important concept which should be kept in mind. So what are the range of services observed, service delivery models? This is community where everything is happening there. And this is rapid test with or without linkage to local care. Now, one thing that I haven't seen in any of the presentations, including Amara's presentations and others, is the concept of reflex testing. And that is that you immediately take a PCR test as soon as a patient is positive. And you please don't need to wait for 20 minutes. If the result is going to be positive on a rapid test, it is going to be positive within 1 to 2 minutes, actually, at the most within 5 minutes. If it is not positive in 5 minutes, it is not going to be positive. So you do not need to get the patient to be seated for 20 minutes after this. I think that is just a defensive measure. That 20-minute is a defensive measure by the manufacturers to say, well, maybe 1 out of 2,000 people will have a positive test in about in 10 minutes or so. So just do a reflex test as soon as something is positive, get a PCR and get that PCR into a lab as soon as you can. In fact, we were also just discussing, and this is a concept that we have tested in our micro elimination program, and we will write it up, is anybody who's PCR positive, and I'm not advocating this because this is not published, but this is an idea. Anybody who's antibody test positive, we were giving them 7 days of supply of SOF and DEC. We would reflex them and send the blood and go back in 1 week. In fact, less than 1 week's time. And anybody who was negative, we would say, okay, fine, you do not need any treatment. Thank you so much. Right, you are positive, you need treatment. Here is the rest of the treatment, and please carry on. The results, unfortunately, are not the adherence results. And we were surprised at this. The adherence results are not that great. Not that great as compared to our usual methodology of testing when we do a reflex and then we go back and give them the medication. I don't know what that reason might be. It may be just that people did not quite sink in immediately that there was something which was there was a serious infection that was going on, even though there was a lot of education and information and so on. So we're looking into that concept. Please remember that 1 week of, and this was our ERC approved protocol. So 1 week of therapy with SOF and DEC will do nobody any harm whatsoever. And this may solve a number of problems and this may be just that what people are looking for as same-day treatment. For many people, same-day treatment means that you do a PCR right there and then. There's a gene expert sitting next into your room. You just stick the blood into the gene expert, get the patient to wait for 2 hours, and then give them treatment, right? So this is the alternate model that we are just proposing. So this hospital-based, specially based, integrated, key populations, etc. This can be just grouped into various things. So just a couple of examples from the global examples about simplifying the delivery. This is from Ethiopia. It deals with hepatitis B, but it is the same concepts. Nurses did initial consults, a point of care test for HBV, HIV, physician reviews in 1 to 12 weeks, triaged by severity, simplified eligibility criteria, either a fibroscan, a higher ALT or a viral load, nurse-led follow-up of people on treatment 2 weeks, 4 weeks, 12 weeks, and those who may not yet be eligible. The results are interesting. This is HCC-free survival. So the results at 5 years of this program: reduced liver stiffness and mortality over time in all groups of patients that were looked at. 21% were lost to follow-up and 15% died. Most had decompensated cirrhosis even at baseline. So no wonder that they died. Those who continued treatment for 5 years had overall adherence of 95%. This is hepatitis B, remember. Of remaining cohort at 5 years, 96% had suppressed viremia. And there is a clear difference between HCC-free survival in patients who were put on TDF therapy, followed up by nurses, as compared to ones
who did not get into this program and did not follow up. So this is another example from India, remote outreach program using a tablet-based platform for linkage to care and returning results. Outreach teams, 2 field workers, phlebotomists conducted screening in central locations, and samples were transported to the lab. So this is partial decentralization. Paper-based results were showed, eligible patients referred for assessment and non-reactive vaccinated. The barriers were the patient desire to speak to a physician, high vaccination refusal rate, especially in children. We have local models. I did not put in details because I thought will not have time to do this. You've already heard the Nankana Sahib program, which is an example of, I would call, partial decentralization, because these samples are still going to a central lab for being tested, and sometimes they're getting late and so on. In the Islamabad slums, Dr. Huma Qureshi is doing a program which is, I think, full decentralization, because the PCRs are also being done almost on site and so on. And we do a lot of micro elimination work, particularly in Malid district in Karachi, which is traditionally has been a very high prevalence area. And this is also partial decentralization, but I would say full, because we do a reflex test immediately. We bring it back to our lab. We go back, as I said, within a week and start treatment at the patient. And all of this happens at the patient's home, not in a clinic, not in a community center or anything. We do have another program from the university where we have about 30 units outside, 30 spokes within the country, which is very similar to the PKLI setup, with 1 phlebotomist, with a couple of nurses, a small pharmacy, physicians, mainly primary care physicians or family physicians, and we deal with we've taught them through the ECHO program how to deal with these patients. And Amara Amara, you would be happy to listen to this. We then developed a WhatsApp group, and that WhatsApp group is the main channel of communication now. And there are 2 heartening things that have happened. One, I still have a message in my WhatsApp group from a non-specialist, from a family physician, which was 2 years ago, who said, "Sir, I cured my first patient of hepatitis C today." So that is still in my WhatsApp box. I haven't deleted it so far. And the second thing that happens, which is very heartening, is when other people in the group start to answer questions that are raised by their colleagues, by their contemporaries. And that is also very nice. So thank you so much. I will stop here. Thank you for your kind attention.
Thank you very much, Dr. Saeed. I hope we'll be collating all the presentations and able to share with the attendees at some later point in time. So now moving on to our last speaker of this session before we go for lunch. So it's my pleasure to welcome Mr. Usman Khalid Waheed. He is the CEO of Feroson's Laboratories Limited, trained in the US at Harvard in economics, spent 30 years in pharmaceutical industry. He is a board member of a range of organizations, and he is leading Pakistan's first biotech plant in collaboration with Gilead Biosciences. So, and he'll be speaking about a health system approach to hepatitis elimination. Welcome, sir.
Thank you so much, Dr. Saab, and I'd like to start by expressing my gratitude first to Professor Saeed Akhtar for convening this meeting, for being such a champion for elimination in Pakistan, and for really playing behind the scenes a much bigger role than he would ever. He's too humble to talk about the things he keeps doing and following up on this issue. But thank you for playing such a massive role in making this first step. It is a first step. There are many challenges to come, but this first step towards elimination a reality. I'm also very grateful to the minister who opened this session today. I think Professor Saidi, you'll remember yourself, Dr. Homi Razavi, and we briefed him in December, and he agreed to champion the cause of taking this PC1 forward at 8 p.m. at night. That's right. And I told him this morning that had he not been this tall, we would have lifted him on our shoulders today and brought him. I'm also very grateful to my colleague Arib, who has done 90% of the work that you see on these slides and helped me manage my time much better. So thank you, Arib. And Professor Saeed, thank you also for putting me right after Professor Saeed Hamid. You made my task. It was always difficult. Now it's impossible. I hope that it will. He's already said most of the things that needed to be said, actually. So I hope this will be a repetition, but perhaps in some ways a reinforcement also of the importance of Professor Said's message. Thank you. So I'll keep this as brief as possible. My talk really has three main agenda sections. One, why the current system is designed for failure, what a systems approach would look like, and what specifically in the case of HCB elimination, we would need to make it look like. Sorry. Okay. So one of our challenges has always been that Pakistan's health system looks like an inverted pyramid. 80% of political investment, political capital, financial capital is put into major tertiary care hospitals like the one we are in today. They play a very, very important role. And going forward, they can successfully drive the elimination process. But over there at the top of the pyramid, it really is not where elimination happens. I don't know if this pointer can work, but essentially 80% of the population lives at the base of the pyramid. And that is where really our health system fails us. Thank you. And if you look at the mathematics of this challenge, as we know, Pakistan has almost 10 million people infected with HCV and about roughly 1,000 gastroenterologists, hepatologists serving that population. If you look at just the number of cirrhotics, at a very conservative estimate, it's about 1.5 million. But as Dr. Faisal Saudar mentioned today, it's probably 3 million cirrhotics that already exist in the HCV population today. Compare this to the 150,000 beds that are available in total in Pakistan. And the fact that setting up a 500-bed hospital would cost 15 billion rupees on average. And if we continue with this inverted pyramid approach to healthcare, to solving our large public health challenges, there's very little chance for us to succeed. And if we were to even if we were to succeed, the cost would be unbearably high. So the challenge really is that we have a very fragmented approach to hepatitis treatment. There are issues around social protection, stigma, the availability of hospital care. We just saw the limited bed capacity we have for treating everything, not just hepatitis. The high cost of treatment, cost of diagnostics, not enough doctors for timely consultation, lack of awareness, insufficient screening. And there is no really holistic approach to solving these really disparate problems. Initially, when I was asked to speak, my talk was supposed to be on innovation in pharmaceutics, but the science behind the treatment is already done. We have cures that reach 97, 98% in success. That's almost as good as vaccinating a population if we are able to treat them all. So that's really not where the innovation needs to take place. The innovation needs to take place in exactly what you see here, which is the patient journey. And in the first block, the community workforce, that's really where we almost have nothing to offer to our citizens. And if we're to actually find those missing millions, this is the part of the system that really needs to be strengthened. Without that, we have really no hope of reaching the end goal. So what is a health system approach? A health system approach is a holistic, integrated, and patient-centered service delivery approach. Our thought process begins and ends with the patient. And there are, of course, 3 layers around the patients that we could use to conceptualize the kinds of solutions we need to come up with. So, of course, there's that immediate community workforce that I just mentioned, the primary care physicians, family physicians, lady health, there'll be primary health workers. There is a workforce around that, but that workforce needs to be trained and organized, as Professor Said very eloquently mentioned in his talk. Then, of course, at the organizational levels, resources, including hospitals, the therapeutics we offer, labs, all of it. There is room for improvement and innovation there, but it's really the system that overall we need to look at together, not just one component of it. And of course, the environment, the policy framework also matters a lot. The stigma, of course, being one example where even today, despite the fact that Punjab has laws against discrimination, many employers across the province here and across Pakistan still continue to fire people if they're found to be hepatitis positive. In the case of an approach to hepatitis elimination, at the environment level, technical partners like PKLI, like Aga Khan, like WHO, like TAG, could continue to work to simplify and simplify the patient journey and introduce more cost-effective diagnostic and treatment algorithms. This will be critical. Offer treatment packages, and I'll talk a little bit about a more holistic Netflix approach that many states in the US are now deploying very successfully, and also other countries are looking at it as well. And of course, laws for protecting citizens who fall ill to this disease and making sure that they're not out of work in addition to having hepatitis. At the organization level, bring advancement in diagnostics and therapeutics, including point-of-care PCRs, high proficiency, rapid tests, better and simpler regimens, and cost-effective treatment. We already, as I said, the science is already there. We just need to bring the cost down, Professor Said, as you mentioned, and perhaps through a national pooled procurement, that scale can be reached where we actually can offer a single pill at the cost of what 2 different pills are costing us today. And of course, around the primary level, I think this is where most of the work needs to be done in upskilling GPs and nurses. Actually, in Project ECHO, it wasn't just primary care physicians who brought that slightly better outcome in a 10-year study. It was nurse practitioners. And that role here can be played by lady health visitors very, very effectively, provided they're given the tools. This is the worst thing to happen when everybody's waiting for lunch. Yeah. So if you look at the Netflix model, which takes really the decision-making away from patients and even actually procurement agencies, it takes the approach of procurement towards a unified approach where you have consortia of diagnostic companies and pharmaceutical companies pitching for a per patient cost or a fixed fee in which the entire population can be screened, treated, and tested. We now have multiple examples in Australia, the state of Louisiana, and Washington in the US that give us enough data to at least run an exercise on what this would look like in Pakistan and whether it makes sense. And I would argue that I think it makes a lot of sense. In terms of diagnostics and therapeutics, we've come a long, long way. If you remember, Professor Hamid, it used to cost 60,000 rupees for the cost of standard interferon treatment in the early 90s. And that would be the equivalent of maybe 3 lakhs today in terms of today's rupee. From there, we went to peg interferon and then to, of course, the directly acting antivirals. And now the cost of cure is much, much more efficacious. It's up to 98%. And the cost itself is a fraction of what it used to be in the past. In diagnostics also, there's been a lot of change in the technology. And Professor Said also alluded to this in his talk. Using early positivity as a marker to viremia, this really needs to be studied further. Of course, if we don't have enough evidence today, for 3-4 years down the road, this could possibly be a dramatic reduction in costs in terms of elimination across the country, and could really help simplify that patient journey where right after screening, perhaps we could start treatment and be fairly certain that the patient we're treating is viremic. Finally, this area of task, not just task sharing, but task shifting, the 3 Ts as consultants like to call it: training, technology, and task shifting. So from a population of 1,000 gastroenterologists, we need to move very quickly to, and of course we have moved. Today, primary care physicians are taking care of hepatitis patients, but we really need to do that massive shift to get the entire pyramid activated. And then you're talking about almost 200,000 community workforce members, vaccinators, community midwives, lady health visitors and workers that already exist in the healthcare system today, but are being used suboptimally. At very low cost, these people who are committed healthcare workers could be used effectively to become hepatitis eliminators. The GPs already are being used, but nurses really, we have not used nurses to their potential in this war against hepatitis. So with this treaty approach, you can see the mathematics becomes a lot simpler. If you were to leave it entirely to trained specialists, the ratio of hepatitis C patients to HCP is 1 to 10,000, mathematically impossible. But if you involve that entire pyramid, it becomes 1 to 25. And if we take screening only to those 200,000 primary health workers and not involve the upper portion of the pyramid, it still becomes only 500 people to be screened by one individual primary health worker. This is absolutely doable. And I think if we are able to catch up with Egypt, this kind of thinking has to be core to that kind of effort. I think there's a lot that we can learn from efforts like Egypt. And having community clinics is great, but if we can go to patients where they live, if we can reach their homes through these lady health workers who are trusted members of their communities, then there is absolutely no reason why we can dramatically scale up the speed with which we eliminate hepatitis. So in the end, systems approach is really, I think, something we need to keep in the center of our planning. And with this, even by all the challenges that we face today, within 2030, I think it's still a possibility to eliminate hepatitis in Pakistan. Thank you very much.
Thank you very much, Mr. Osman. I think we have a few minutes for questions. So if there are any burning questions for the panel. Sir. Mike.
So there's a based on what we have just heard, there's a paradigm shift in the entire thinking process. And I think if we want to make this program successful, we really have to create a large force or use the existing large force that exists at the doorstep of the patients. I think that's very important take-home message. Secondly, as Dr. Said Hamid said, that we have to really decentralize. And we saw that in our program where we were sending the specimen to Lahore, we did run into a lot of difficulties at that time. The problem at that time was we explored the concept of utilizing the gene expert at that time as a point of care testing at site, but that thing was very expensive. They would not give us a discounted rate. I had a big fight with Mr. Kola, Martin Kola, who was their regional head, and we could not bring the prices down. So that was a problem. But I think with the newer RNA testing methodologies which are evolving, that may be a reality for the future. Also, I think we were talking here a minute ago that would it be worth it if a nurse goes to the home of the person, does a finger stick is positive, draws the specimen, and then just hands over the DAC, a soft DAC or soft well, whatever is the protocol. And then as the result comes back negative, we stop the medication if the result is positive. So I'm just sort of loud thinking so that the cascade. And in the meantime, if it is positive, I think then we need to get some more parameters and more information on what the APRI score is and what does the person need a fibroscan and whatnot. So that goes from goes to at least a primary care or maybe higher level of care. So some sort of protocols have to be. So whatever we are doing, I think, and I think the take home of the entire session from today so far is that we really have to develop a very robust technology-based softwares to communicate and coordinate with the entire process. So the person who's doing a sampling in Sindh, a rural Sindh, their database can be looked into Islamabad or wherever the central monitoring mechanism. So a lot of things, COVID has taught us a lot of things. I think we need to go back on the table and learn how we dealt with COVID and what technology did for the COVID. And I think, so people who did it like 10 years ago or 5 years ago, I think the job for us is going to be much easier and much more simpler than what it was 10 years ago.
Thank you, sir. Well, with that comment, we'll just break off for the lunch. And I will request everyone to be back in this hall by 3:45. So 3:45, so that we can promptly start with the next session. And the minister, and there will be other panel discussion at the very end. So I thank you all for your patience and all this, and well, thank you very much to all the speakers.